Morning, Reddy bhai.
Vasu, are we ready? Vasu, do we have Brendan Levine joining?
But I think it 10:08. We can start.
Do we have Brandon Levine?
Yeah,
Yes,
he's here.
I'm
He's here.
right here.
I see him.
Good. So we can start. We can start then. We can start.
You like me to start?
I think let Chetan start. Huh? Chetan.
Okay. And everybody can put yourself on the mute. Please mute your microphone.
Here, I will do that, Chetan.
Okay.
I'll mute everybody. Mute all. Okay. It's all yours, Chetan. Oh, you are muted too. And Subhash, you can unmute yourself.
Okay. Guys, good morning to everyone. What a pleasure morning. You can see this event will give an opportunity to meet each other virtually. And you can see everybody is smiling, everybody is saying hi, good morning. That's a real success of USAP's event. Now, you can see in this year, we done several years. Actually, I can say this year due to COVID-19, we are not able to do event physically, but this is one of the most successful year of the entire year. This year, you can see we done maximum number of event. Now, this is third year of the USAP, and it is going to be end very soon after 2 months. So USAP is going to complete 3 years. But in this 3 years, this is the first year where we conduct maximum number of event, maximum number of Pittsburgh and outside the Pittsburgh people take the advantage of event. We have maximum number of membership this year. So I can say this is the biggest benefit of the COVID-19. They bring the people more and more together. We can try to care of each other very well. And that is happening due to COVID-19. Last week, I read one sentence in one of the WhatsApp chat. Okay, this is the first year, 2020, where the people worship the God maximum number of hours. We never worship that many hours in the God. We never remember the God that many times in past. This is the first year we try to go more and more closer to God and worship as many hours as possible. But that's fine. So first, I like to thanks to each and everyone for your wonderful support to the USAP, because due to your support, that will give a lot of encouragement, and that encouragement will prompt to conduct so many programs on various topics, not only health or the fitness, but you can see we conduct on finance, travels, and so many things. And another thing, the very important part of USAP is USAP knows what senior community need, and we always bring the program on timely basis. We know what time, which program to be brought. And you can see this is the, in 3 years, first time we are going to bring this program, the hearing loss in seniors. This is one of the important topic. And we all know after 50, our hearing will be go slowly down and down. And after 75, 50% we have hearing loss and everything. So today's presentations will definitely help help a lot. They will teach us how we can prevent the hearing loss, what care is to be taken, so that will be useful. And because sometimes we are very lazy for ENT, we never go to the doctor visit and everything. So today our Dr. Vasu and Todd will tell us a lot of information. Okay, we should do the preventive checkup and all these things so that we can prevent hearing loss as much as possible. Now, another thing, still we have 2 more months because today is the 1st November. So November, December, 2 more months to go. And we are going to bring couple of more events, at least 1 or 2 more events before end of 2020. And that will be more exciting event will be on the way. So we will let you know in upcoming days. But now it is already 10:12, so I'm not taking much time. And I like to invite my USAP Secretary, Dr. Subhash Ahuja, to introduce today's our wonderful speaker, Dr. Vasu and Dr. Todd. Subhash Ahuja, over to you.
Thank you, Chetan. Can you all hear me?
Yes.
Good. I'm just, it's a little introduction just to
Yeah.
say that hearing is a blessing. We can all hear each other, and just imagine that the hearing was not there. I think we do as we age, a healthy aging, a part of the wear and tear of healthy aging does diminish our ability to hear. And it becomes a frustration in the joy of living when the hearing loss happens in your later age or part of your life. And so this is a very important topic. We have touched many medical topics before, but this is a specialized area that we do, our senior citizens do encounter this problem. And we're very happy that we have a specialist in this field, Dr. Vasu Malipati, and his associate, Dr. Todd Hillman, and also an audiologist, Brandon Levine, are here today, and they will be discussing the details of this whole problem. Um, um, Besides hearing, we had encountered loss of sight, loss of smell, loss of touch, loss of taste. Those things can also happen, but much more common are the sight and the hearing problems that we have. In fact, hearing at old age is understandable, but sometimes hearing occurs earlier in the age, younger age also. So there are lots of things to discuss about, and we have plenty of time today. So I would not take any further time. I just simply want to introduce to you Dr. Vasu Malipati. Dr. Vasu Malipati is an MD, graduate from Shri Venkateshwara Medical College in Tirupati, India. Did his post-graduation at Christian Medical College, Vellore in India. He completed his residency training in ENT at Case Western Reserve University in Cleveland, Ohio, followed by a fellowship training in head and neck surgery at the Albany Medical College in New York. Then they moved to Pittsburgh in 1986, and he has been in practice at Mon Valley Hospital for the last 30 years and only recently retired. He is a charter member of USAP, of one of our own senior citizens member also. And he's enjoying his retired life with his grandchildren. And one thing unique about Vasu is that he also has been serving the community at large, along with his wife Durga, who's also a physician. They go traveling at medical missions all over the world at times of disaster or even otherwise, rendering the services where it's needed. That's very commendable of Dr. Vasu Malipati. And so he is accompanied by his associates, as I mentioned, Dr. Todd Hillman at the Allegheny General Hospital, who is specialized further in the hearing problems only. So his specialty is very narrow, and I'm glad he's able to join us. And then after the problem, like we go to the optometrist to do our eye refractions and glasses, we have an audiologist, Brandon Levine, who will also help us understand what is involved with this hearing aids after that. So with that, not taking any further time, I would give the floor to Dr. Vasu Malipati. But just before that, I would also remind you, everyone will be muted so to avoid all interference, and we'll entertain Q&A towards the end of the program, again to avoid confusion in between. But if you do have any question to ask, you can feel free to ask them also if it's an important question. Otherwise, wait till the end of the program to have a Q&A session. And so with that, Dr. Vasu Malipati, if you can please unmute yourself and the floor is yours.
Good morning to all.
Good morning.
Vasu, 1 minute, let me share your screen. Vasu, can you see the screen?
You will share. You will show slides.
I can, Chetan.
Yeah, we can see it.
He's going to share the screen. Let him- yes. He's going to show.
Yes, Vasu, you can go ahead.
Let me. Let him. Yeah. He's going to show the slides. Yeah. Can you see the slide now?
Ah,
Can
yes.
you? Yeah. Good morning to all. Thanks for the USAP for this opportunity. So as you will go, basically first we'll go introduce the anatomy of the ear. Ear is divided into three: outer ear, middle ear, and inner ear. Outer ear consists of pinna, external artery canal, and the eardrum tympanic membrane divides external artery canal and middle ear. And middle ear consists of three smallest bones called malleus, incus, stapes. And there is a eustachian tube opens into the middle ear from the back of the nose. It equalizes the pressure between the middle ear and the external auditory canal. It is equal pressure is important for transmission of sound. So inner ear consists of cochlea and semicircular canals. Cochlea is for hearing and semicircular canals for balance. From cochlea, the cochlear nerve, and it goes to cochlear nucleus and temporal bone. So the sound waves collected from the pinna goes through the external artery canal, vibrates the tympanic membrane, and magnified in the middle ear bones by malleus, incus, and stapes. It increases about 25 decibel increase and goes to the into the inner ear. Inner ear, there are small air follicles called inner ear cells, which convert sound waves into electrical impulses, which goes through the cochlear nerve and to the cochlear nucleus and temporal bone, where sound will be recognized. Next slide, please. How do you manage hearing loss depends upon various conditions, most of the 95% are hearing loss are treated medically. 5% only need surgical treatment. And also you have to know where is the site of the lesion, whether it's a conductive hearing loss, sensory neural hearing loss, or mixed hearing loss. Conductive hearing loss is only in the external artery canal and middle ear. Pathology will cause conductive hearing loss. As sensory neural hearing loss, anything in damage to the inner ear to the cochlea and cochlear nerve will cause sensory neural hearing loss. We have to identify where the site of the lesion and the nature of the pathology, whether it's infection or tumor, whether unilateral or bilateral. Whenever there is unilateral hearing loss, you have to be very concerned to rule out acoustic tumor. So we usually do MRI to rule out an acoustic tumor in unilateral hearing loss. Next slide, please. So what kind of hearing loss? Type of hearing loss. Mild hearing loss is up to 40 decibel is mild hearing loss. 40 to 60 is about moderate hearing loss. 60 to 80 severe hearing loss. Above 80, 90 is a profound hearing loss. So you have to know how much hearing loss is there. Treatment depends upon what kind of hearing loss you identify by audiological evaluation. Next slide, please. So incidence of hearing loss, about 40 million people in the general population is affected with hearing loss. Most of the people, they don't come for treatment. A lot of postponement, or they don't have availability of medical management, availability of medical health care. About 1 in 3 age, 65-74 years, there's about 30% will have hearing loss. In about 65 and 74, it increases to 50% those who reached above 75 years. Next slide, please. So what is the impact of hearing loss? It will impact your job performance, It will relationship with the spouse and grandchildren. You can't hear grandchildren conversation. You have to ask them to repeat. They get very mad. And driving also, if you can't hear driving next car or a horn, you are getting into accidents. Socialization be affected, and the loneliness. It can release to depression, anxiety, and 12% of the dementia patients having hearing loss. If you evaluate them and treat them, the dementia symptom may get better. Next slide, please. What are the causes of hearing loss? Most common cause of senior citizens age and noise. These two combinations is the majority of the causes, majority of the reason for hearing loss. And heredity is more in a younger generation, like atherosclerosis. Is a middle ear bone is fixed with the new bone formation, and the stapes will be fixed. That need to be usually that need surgical intervention. Sometimes they can go for hearing aid also. 50% of the sensory neural hearing loss are genetic predisposition, and in Afro-American people, hearing loss is not as bad as white people because of they have melanin pigment which may be protecting them, and comorbidities with atherosclerosis, diabetes, hypertension, hypothyroidism, smoking, they're all associated with hearing loss. And diabetes, especially, some people will come with hearing loss and we diagnose diabetes at the time. It can be sudden or it can be a progressive hearing loss. Trauma sometime, Q-tip injury, slap on the face, and auto accidents, gunshot wound injuries, etc. They can cause hearing loss. Next slide, please. Infections. Next, previous slide. Infections where there is otitis media with which can be treated with medical management. Cholesteatoma is a skin in the wrong place, skin cyst, which has to be removed. Otherwise, it will corrode into the cause of meningitis, more hearing problems. And systemic disease like COVID, meningitis, mumps, etc. can cause also hearing loss. Tumors, primary tumor like acoustic tumor in the cochlear nerve tumor, which slowly progresses, unilateral hearing loss. They need to be evaluated with MRI and treated surgically. And the secondary tumors, but mets from anywhere, any malignant secondary mets can into the temporal bone can cause hearing loss. Ototoxic medications, very common cause of our hearing loss, especially chemotherapy and hydrocodone, large dose of aspirin, ibuprofen, antibiotics like Zithromax, furosemide, etc. They can cause hearing loss. Autoimmune inner disease, it could be primary or it could be secondary. Lupus, sarcoidosis also can cause hearing loss. And in neurological disease, multiple sclerosis and strokes. Stroke can cause cerebral hemorrhage, and they can have some hemo blood in the inner ear or middle ear can cause hearing loss. Next slide, please. Noise-induced hearing loss is more, you have to prevent noise-induced. Normal conversation is about 60 decibel. When the lawnmower is 90 decibel. If lawnmower professional people using lawnmower for 8 hours, they're prone for hearing loss, and they should use ear protections. Music concert, younger generation is very common when they're exposed to loud music near the speakers, and we see a lot of younger generation with hearing loss problems. Ambulance and fire workers, they're all very exposed to loud noises. They have to use, according to OSA requirement, they should use ear protections, earmuffs, and they have to measure decibel meter. Next, please. So prevention of noise-induced hearing loss. Brief exposure is hearing loss will reversible, but 60-60 rule is 60 minutes, and 60% of the volume of the CD player or MP3 player. You should not listen, not to listen more than an hour. Especially younger generation, they listen too long and they get into a lot of hearing problem. Future, more and more we'll see hearing loss in increased incidence of hearing loss because of noise exposure. Headphones are better than earbuds. So it reduces about 35 decibel hearing. Decibels, reduce 35 decibel noise, so it will protect the hearing. So headphone is always better to wear in noisy environment. Next slide, please. So what are common diseases? I'll talk about for a couple of them. Then Dr. Hellman will talk about the middle ear and the inner ear. Wax, external ear, otitis externa, middle ear barotrauma, otitis media infection, otosclerosis, as I mentioned, middle ear bone is fixed with the new bone growth. So inner ear is a sensory neural hearing loss, Meniere's disease, and acoustic humor. These are the common causes for hearing loss. Next, please. Wax is normally wax cleared by itself, but sometimes it will. It is good to have some wax because it's a lubricating, anti-itching medicine. Anti-itching is anti-infective. It blocks the dust also. Sometimes people use Q-tip and push the wax inside the close to the tympan membrane, and wax will form behind the pushed wax, and they can cause conductive hearing loss. And some people have a narrow ear canal. They can cause blockage of the ear wax, with some produces excessive wax. The combination of narrow ear canal, excessive wax, and sometimes pushing it through tip, it can cause conductive hearing loss. Next slide, please. Which wax, it can be easily, as I mentioned, it will come out by itself, but you can use some drops or oil to soften the wax. Some people use once a week, some and nighttime, and let it come out in the morning. Sometimes if it's excessive wax formation, they need to be suctioned out, curate, removed with curate or syringe. Annual cleaning is some people need annual cleaning. And in Guyana, I mentioned, as I mentioned, I like to go to medical missions. When I was in Guyana, one gentleman with 70 years man came with a bilateral impacted cerumen. I cleaned it out. What he said, "You're a God to me." It's a very touchy experience. So wax, even though simple wax, it will cause a lot of conductive hearing loss. So actually, those who have problems should get it cleaned at least once a year to hear better. Next slide, please. Otitis externa, it is a swimmer's ear. It is more, it could be a bacterial, fungus, or viral. We have to sometimes we do cultures. Depends upon it will cause pain and hearing loss, especially in diabetic patients. It will be very severe infection will produce. They need to be they may need sometimes systemic antibiotics, debridement, and alcohol vinegar is the best. Alcohol is a drying effect, and vinegar is acidic effect. So you can make your own alcohol vinegar and use it for, especially when you're going swimming, or use earplugs, or sometimes use Cipro antibiotic, Lotrimin for antifungal treatment. Sometimes you'll insert a wick to keep the drops inside the ear. So for especially children, they use better to use earplugs or alcohol vinegar drops. You can make it at home, and it will help to prevent otitis externa swimmer's ear. Next slide, please. Barotrauma, which we all experience in ears when a rapid descent in the airplane in the low altitude, especially descent time, you get it into problems. So yeah, sometimes some people use earplugs, but swallowing exercise helps. Chewing candy or chewing gum. Valsalva exercise, like close nose, close mouth, and blow into the air, that will help open the eustachian tube. It will help to reduce the barotrauma. You can use a nasal decongestant, oral steroids, oral Sudafed, especially if you are cold or anything, better to use some steam inhalation before you start your flight. Sometimes you can use nasal steroids. If persisting fluid, we do use some oral steroids. If it's an added infection, we start some antibiotics. If persisting fluid more than 2-3 months, we may consider tube or laryngotomy, remove the fluid out. Next slide, please. Children has a small children have a large, wide, straight, horizontal eustachian tube, so they are more prone for otitis media and barotrauma. Adults are linear type, S-shaped, so they are less common compared to children. Next slide, please. COVID is in the New England Journal of Medicine recently published an article on COVID. 13% of the COVID patients developed sensorineural hearing loss. It could be a COVID virus can affecting the inner ear, or it could be a side effects of ototoxic medication like a Zithromax, furosemide, combination of medications, or virus attack to the inner ear. So this patient had undergone a cochlear implant, intratympanic steroid, and he got it better with the after treatment. Next slide, please. Transparent mask is very nice to have, especially when if you're talking to hard of deaf people, especially hard of hearing patient, more frequent conversation. You should use a transparent mask so that they can use the lip reading, and they can conversation will be improved. So always try to wear a transparent mask when you're talking with deaf people. Next slide, please. Suggestion for hearing loss patients: lip reading, which is helpful. Sit close to and face the speaker. Sit at the front of the stage. Talk in the same room. Assistive listening devices, which Brandon Levin is going to talk about it. Talk in the same room. Suppose if wife is in the kitchen and you are in the family room, you can't hear. So better to be in the same room when you're talking. And next slide, please. This is Helen Keller, is from Alabama. She's at the age of 2, she developed meningitis and developed hard of hearing and blind. She went to Boston, she got treated, and she developed sign language, and she became a writer and college graduate and traveled all over the world. And one journalist asked her, would you like to have, if the God gives you back, would you like to have vision or hearing? She said she would like to have hearing rather than vision. So hearing is very important for all of us. So try to get in evaluation whenever you have a problem with hearing. And Todd Hillman is very available. He's an otologist. He does only ear cases. He's further enhance our knowledge on hearing, and he will answer all the questions and answers on hearing evaluation and further information. Thank you. Thank you very much. With this introduction, I would like to introduce Dr. Todd Hillman. He's again a general hospital otologist. He's well-versed, well-trained, and I recommend, if I need a hearing problem, I'll go to him. Thank you.
Thank you, Vasu. That was very kind of you. Excellent talk. I'm going to share my screen now. Hopefully, I'll get get this on there, right? So there's going to be. Is it up and running? Is that everyone can see the talk? Good. Vasu, that was a very nice presentation. Yeah, I do subspecialize in hearing loss, among other things, disorders of the ear. I'm going to try to summarize about 20 years of experience into about 20 minutes. So bear with me. It might go quick. Vasu had talked about Helen Keller, and we're talking about loss of senses, and obviously we always think of sight and hearing as our two main senses. And I think most people would say, well, I'd rather maintain my sight than my hearing. But Helen Keller, Vasu is right, had a very unique experience. She was born with hearing and sight, lost them both, and had a unique perspective about how she felt about losing her hearing. And her quote that's famous was, "I am just as deaf as I am blind. The problems of deafness are deeper and more complex, if not more important than those of blindness. Deafness is a much worse misfortune. For it means the loss of the most vital stimulus, the sound of the voice that brings language, sets thoughts astir, and keeps us in the intellectual company of man." And to summarize, she stated, blindness separates us from things, but deafness separates us from people. And while most of us wouldn't necessarily agree with that completely, she had a very unique perspective. And she's right, deafness does isolate us from people, and it sneaks up on you, especially presbyocusis, the most common cause of deafness. And we have Brandon, an audiologist, here to talk today about the treatment of presbyocusis, hopefully. And but it is important. You start people when you are around people with hearing loss from advanced stage, you don't treat them the same. You try to, but if they can't hear you or understand or miss words, the interaction changes, and that can cause all sorts of complex social issues. So Vasu already talked about the physiology of the ear. The ear is simply just a way to transform air vibration, which is what sound is, just air molecules vibrating, into an electric signal. And it does so with collection of sound to the eardrum, which then vibrates mechanically into the inner ear, and the inner ear, mainly the cochlea, turns that into an electric signal, and that the brain can understand and turn into a sense that we understand. The first part of the ear canal and the eardrum and the ear bones overcome what's called the impedance of the ear, which is a phenomenon that you see when sound is trying to travel from the air to a fluid medium. If we were not to have an outer ear or a tympanic membrane or ossicles, most of the sound energy would just bounce right off our heads and go out into nowhere. And we'd be left with a 30 decibel hearing loss. And so the eardrum and the ossicles overcome that for us. And it does, the most important part is the eardrum, the tympanic membrane. And the eardrum is a pretty large structure. Well, large in my world, it's like 1 centimeter, which I operate, I'm in the microscopic world. But it collects sound from a very large area. It shields the round window, which isn't that important for our talk, but then takes that sound and collects it into a very small area. It concentrates it. And so you really do need an intact eardrum and an intact pathway to the eardrum for sound to get there. Effectively, the effective vibrating surface of the eardrum is 17 to 1 ratio to the effective moving area of the stapes footplate. And that's a large force concentration. Most of us here probably know a little bit about ear bones or ossicles. There's 3 of them. They do provide a low frequency amplification. It's not as important in higher frequencies, but that the system altogether translates into a pretty large gain of hearing. That vibration then gets into the cochlea, which is what we refer to as the inner ear when we're talking to patients. That stapes ear bone will vibrate the fluid space that surrounds another fluid space called the scala media, where all the nerves are, the nerve endings, and that's where the magic kind of happens. And the cell that turns that vibration, that mechanical energy, into an electric signal is called the hair cell. And it's called a hair cell because it has little tiny microscopic hair-like projections which move, and when they move, it generates electricity into the cell, which then signals the nerve of hearing in a way that the brain can understand. And there's 2 types of hair cells. One is the inner, which is the one that transmits or turns the vibration into sound. And then there's the outer hair cells, which we believe actually suppress background noise. It's pretty interesting. So it goes both ways. The inner hair cells absorb the vibration and turn it into an electricity. It goes through the brain. The outer hair cells will stiffen the tectorial membrane, and the opposite phase of sound coming in. So your ear actually has a sound filtration mechanism. And this is pretty hard to replicate with hearing aids. It's getting better, but a lot of patients who do hearing aids, they don't like the background sound, then because they lose a little bit, they don't have this inner ear function like they used to. But hearing loss, like Vasu talked about, can be broken into 2 main categories. Conductive hearing loss, where the ear canal, ear bones, or eardrum don't work right, or nerve loss, which is a disorder of the cochlea, hair cells, or the nerve of hearing. And there's quite a few different problems in each category. You can have what's called a mixed loss, which is a loss that combines the 2 as well. Well, I'll talk about a few of these in each category, but the most important part in the sensorineural category is presbyocusis, which is age-related hearing loss. It dwarfs all of these conditions. However, it is important when you're getting evaluated for hearing loss for a physician to at least one physician visit, possibly to rule out all the other causes, because a lot of these require surgery or further workup to make sure there's not pathology being missed before proceeding with amplification or hearing aids. And audiologists are so well trained in this country now that they can pick up on a lot of these disorders and make proper referrals. You don't have to go, if you do have one of these, they'll recognize it, send you to a physician, but most patients should see a physician at least once, in my opinion, for hearing loss workups. Tuning, you'll see tuning forks still used. The audiogram or the hearing test is the mainstay of diagnosing what type of hearing loss you have, but tuning forks will separate out the hearing loss from conductive and sensorineural loss. Basically what a tuning fork does is it vibrates the bone directly, bypassing your eardrum and ear bones. And so if you hear the sound louder through your bone than you do through the air, you have a conductive hearing loss. But if you went to a physician for a workup, they would use tuning forks. But the audiogram, the hearing test, is really the mainstay of how to diagnose the degree of hearing loss and the type of hearing loss. And the two major categories are conductive and sensorineural. So on the left side of your screen, well, when you do a hearing test, the audiologist will put earbuds in your ear canal, and that tests how well you hear through the air. And then they'll bypass your ear by putting a device behind the ear, a bone conductor. And so if your bone conduction is relatively normal, but you have hearing loss, you have a conductive hearing loss. Whereas if both are the same, it's a sensorineural hearing loss. This is a very common audiogram for someone with age-related hearing loss or presbyocusis, where the low frequencies are pretty normal, but the high frequencies go downhill. These patients always come in and say, well, you know, doc, my hearing's not that bad, but my family's complaining. And it's because they hear words being spoken at a normal level, but they're not very clear because the consonants and the nuance of the words are being lost because of the high frequency hearing loss. Anyway, the audiogram really helps us separate out these two categories. And that's important because typically for conductive hearing losses, surgery is often corrected depending on the problem. Whereas for nerve loss, we have to do amplification, or maybe if it's severe enough, cochlear implants. There are ancillary hearing tests that I won't get into. If you do get an evaluation by an audiologist or doctor, sometimes there's electrical tests that in complicated cases help us out. There's air pressure tests, otoacoustic emissions, and other tests as well. Well, as Vasu talked about, one of the most common problems is wax. And so wax can block the ear canal. It won't let sound in. You're actually hearing through your skull more than your ear canal when it's really blocked in. But wax is very healthy. You need a little bit to prevent ear canal infections, but too much and it gets blocked. And so removal does help the hearing. Now, patients always ask me about ear candles, and then here's my take on it. So what an ear candle is that you put a candle in your ear, you light the other end on fire, and it creates a mild vacuum that supposedly pulls the wax out. This has been studied by scientists, and the candle looks the same whether or not it was used in the patient or not used in the patient. The wax in the candle looks like ear wax. It doesn't create enough suction really to pull the wax out, and so I don't recommend this. Interestingly enough, there are 50 house fires every year caused by ear candling. I thought that was a big number. It's not that many for the whole country, but I thought that was pretty interesting fact. So removal by a professional, if it's totally impacted, is usually what's most helpful, either by very mild irrigation or a professional like Dr. Vasu or myself would do under a microscope, just removal of the wax under direct visualization. Either one's acceptable. You can get a little bit of, there's a small rate of, if it's not done correctly, a perforation with irrigation. All right, so we'll get into like briefly specific problems. When I'm seeing a patient for hearing loss, they have a whole, problem with the conductive system, and there's no wax, but there's a hole in the eardrum. Well, that's obviously going to decrease their hearing. And this is usually caused by infections as a child, ventilation tube placement, sometimes trauma, but these can be repaired with about 90 to 95% success with just one operation, and a 95 to 100% success with a follow-up operation if it's necessary. But the ear heals really well with outpatient surgeries. And I won't get into details. This is just showing one technique. But if you have a hole in your eardrum, we can rim the perforation, elevate the ear canal of the skin, and replace the perforation with your own tissue. And it tricks the body into healing it. And it's highly effective. Sometimes the ear bones are not working, and so we have to correct the discontinuity in the ear bones. After multiple infections, if the incus is eroded, we can bridge the gap. If it's completely gone, we can, but your stapes is still okay. There are prostheses for that. We just put it against the eardrum. And if the whole thing is missing, we can even repair that with something called a total ossicular prosthesis. There's a variety of techniques, a variety of materials out there. All we're doing is reestablishing the connection from the eardrum to the oval window. These are not perfect. They're not as good as what you were born with, but it can certainly improve sound. And I do these operations. Sometimes those operations don't work. I see a lot of very complex patients with bad ear problems that they just won't heal correctly and the hearing won't. So if you have a really bad conductive loss or a mixed loss where conductive components are pretty significant, you can bypass the ear altogether. Just like we talked about putting sound on the skull directly, you can do an implant in the through a titanium implant that was actually originally designed for dental implants, called a bone anchored hearing aid. And you let it heal, it integrates in the bone, and through an abutment, you can attach a hearing aid directly. Now, these are cumbersome. They're pretty, obviously you can see them. They're pretty visible. This is an older one. Because the titanium post sticks through the skin, there can be healing issues in about 10% of patients with chronic irritation, but the sound quality is amazing for patients with conductive loss. And it actually vibrates both cochlea, so you get sound to both ears with one device. There are issues with this device, again, with the skin reaction. And so what's happened is that they've come different companies have tried to put the main device, the actuator, under the skin, so there's not a post sticking through it. The initial one was the Syphono with 2 magnets. You put this under the skin, let the skin heal, and then attach with the magnet, the hearing aid attached to a magnet for conductive hearing loss. These were not powerful enough and didn't work well, and they hurt to wear because they pushed really hard on the ear. As a result, there was a device called the SoundBite that we did a lot of research on, initial research on, that you can actually put sound through your teeth. It vibrates your skull. It's kind of interesting. You did a device that tightly attached to your teeth. It was actuated by a microphone and around your ear. These again weren't very powerful. The fit from the dentist had to be perfect, and this company is unfortunately no longer in business. But that evolved into much better devices that are out there now. Cochlea, which makes the Baha, also makes an under the skin device called the Ossia. It's new. It goes under this part goes completely under the skin. This is the magnet and this is the actuator. Unlike the Syphono, you don't have to put the device directly on with the implant. It can be a very light connection through the skin. This is the skin would be here, and it drives the device. It puts sound directly into the calvarium and into the cochlea. And it's a very powerful, good device. MED-EL also makes something called the SoundBridge, which uses a vibrating magnet called a VSB, but it does the same thing. Again, so the implant's under the skin. You still have an external device that's bulky, that powers it, and that serves as the microphone, but these are coming a long way. We've done some research on other devices called the Vibrant SoundBridge. This is a pretty interesting device that attaches that was designed to originally attach to your ear bones. It was used for nerve loss, for sensory loss, and it was better than hearing aids because it was more powerful, but obviously very complex device to put in, and pretty expensive for a hearing aid, about $18,000. And but it has an under the skin component. We would insert, we go behind the ear through a facial recess approach, attach it to the incus, and then we powered by an audio processor and behind the ear. It still had, I did this for a couple of sensory hearing loss patients who loved it. The sound quality was amazing, but the cost is prohibitive. And a lot of times it's not covered by insurance. But it turns out that the gains were amazing compared to hearing aids, very high quality sound. But it turns out it had a better a better indication for conductive losses for patients who don't have the eardrum or ear bones that we couldn't repair it. And what we do for those patients is that we'd implant it directly on the round window. We've just finished a trial with that, and patients did quite well. What we do is take the floating mass transducer and stick that right on the round window, where the sound energy is supposed to come out. We just put the sound energy into there. It doesn't cause a problem. Patients don't hear in reverse. They actually hear pretty well with it. And the gains are amazing. It not only bypasses all of the eardrum and ossicle problems, but also can amplify to compensate for any nerve loss that's there as well. And unfortunately, and Coletti was the first to do this in Italy. We did studies in the US. It's FDA approved for this, or it's not FDA approved. That's the problem. They haven't finished the FDA approval. They went through the first few phases, and they still have some work to do. But that's going to be a pretty good boon for patients with nerve losses that are pretty severe on top of ear bone or tympanic membrane issues. So, and then again, I won't show the gains, but here it is implanted. So this is the mastoid. This is behind the ear. It's in the round window area, and very good device, but unavailable just yet. So there are other issues that I deal with conductive component. Another very common problem is something called otosclerosis. That's where the last ear bone is frozen. It's idiopathic. It's the stapes bone that gets kind of locked in position. And you can actually do a surgery to fix that. We elevate the eardrum here. I'll go through it quickly for the interest of time. Get into the middle ear, find the issue here, which is this is the second ear bone, the incus, the stapes. Separate those two, and if the stapes is in fact fixed, you can laser it off, laser the top part of the stapes off, leaving the foot plate, and bypass it. Here's the foot plate. It's not moving correctly. Do some measuring, laser a hole in the foot plate. And this is your inner ear now. This is the vestibule. This is where the sound energy goes in. This is the right ear. And put a prosthesis in. It's a very common operation. It's been around for decades. It's been refined over the years. This is the prosthesis going in here. It's then crimped onto the incus. 90% success rate. Very rewarding surgery to do. And outpatient. But again, unfortunately, otosclerosis, well, yeah, unfortunately, it's not the most common cause of hearing loss because it is a very highly successful surgery. But again, kind of just emphasizing the point that if you have hearing loss, we're getting an evaluation to determine what the cause is very important. There's other inner ear problems that can cause a conductive hearing loss. One is called superior canal dehiscence. I won't get into that. But again, a careful evaluation to determine the cause of the hearing loss is often important. Some patients will experience what's called a sudden hearing loss. This is fairly common. It's like 1 in 5,000. You'll wake up one morning and the hearing will be gone in one ear. 1 in 5,000 chance of having that per year, per individual in the United States. Most of the time, this is not something we can figure out what the cause is, but about 1 out of 50 will have a tumor. So if you have hearing loss in one ear and it's a nerve loss, your doctor typically will recommend an MRI. If an audiologist is seeing you, they'll recommend an evaluation by an MD to order an MRI to make sure you don't have one of these. Again, thank goodness this is only about 1 in 100,000 incidents, these tumors, but the sudden hearing loss is about 1 in 5,000, pretty common thing to see. So the most common cause of hearing loss, though, and Vasu talked about this, is age-related hearing loss. This is the big thing. And it probably does have a hereditary component. I see patients with hereditary patterns, but it will hit you at some point in your life if you get old enough. I mean, it just happens. About 70% of men at age 70 have presbycusis. About 60% of women have it. They're spared by about 10 years, fortunately. And it is exacerbated by anything that decreases blood vessel supply, such as hypertension, diabetes, tobacco use, and arteriosclerosis. It's accelerated by that. Most of it's at the hair cell level, damage to the hair cells, also to the nerve of hearing, however, And this is a typical audiogram that you'd see in presbyocusis, where the lows are normal, the highs frequencies are bad. And so patients sometimes feel like, well, I can hear everything, but it's not clear because they're not hearing all of the frequencies. Or, yeah, this is like a piano. This is the last key on the right in a piano, 4,000. This is middle C. So if you're missing 1/30 of your piano, imagine what your music would sound like. And that's what speech sounds like when you have this pattern. This is the most common pattern. There are a couple different forms of presbyocusis. One is most of it's hair cell disease, some of it's neural, and it can cause not only poor detection of sound, but kind of a disturbance of, it can cause poor discrimination. And so hearing aids can be frustrating in that group of patients, but the only way to know is to try them. Now, with all the fancy technology that's out there, with all the strides that have been made with hair cell regeneration, with the unique devices, by far and away, the most important device we have is still the hearing aid for amplification. And in the background, while other companies have been devising unique ways to address hearing loss, the hearing aid companies have been improving their product and at a faster rate than novel technology has. And these little things have a lot of technology in them to filter out background noise, to make sounds clearer, for feedback control, so you don't have to clog the whole ear canal most of the time nowadays, for power, for battery life. And so this really is the mainstay. And probably, 90% of the patients I see with presbyocusis still benefit from amplification. The earlier you use it, the better you do with it. The later you adopt it, your brain has made some changes that makes it more difficult to transition, and that's why so many patients don't. If they are late adopters, sometimes they don't do well. This is a totally implantable hearing aid. It's out there. If you want to pay $35,000, instead of wearing something in your ear canal, you can get it completely under the skin. It's hard to put in. It doesn't work on everybody, and it does require destruction of the ossicles. The Envoy system is FDA approved. It's out there. Not that many are being done anymore, but we did the first initial trials in Pittsburgh. We were part of that. And it uses your own Incus as the microphone, and it drives the stapes. It's about, in our hands, it's about a 4-hour, very difficult surgery. I don't recommend it, but people on the West Coast and East Coast, they have the money, they're still getting it. But the conventional hearing aids are so small and so good nowadays. I don't see a role for the Envoy system at this point. So in the interest of time, I do want to talk about what happens if you're advanced hearing loss, your age-related hearing loss, or if you have a genetic condition that causes premature sensorineural hearing loss in the profound range. What happens when hearing aids don't work anymore? And there is hope. Something called a cochlear implant can replace your cochlea. So your cochlea's job is to take mechanical energy and turn it into an electric signal your brain can understand. If you have really poor hearing and you can't understand speech anymore with good hearing aids, we can insert an electrode into your cochlea, have an under the skin device that's called a receiver, powered by an external device that will give you meaningful sound. Patients don't go deaf anymore if they have normal cochlear anatomy. They can, most of the patients who get a cochlear implant, I mostly do adults, but most adults that need a cochlear implant can function relatively normally with regards to speech. It's not perfect. Music is difficult. The sound is still distorted. It's kind of a crude sound compared to normal hearing. But cochlear people don't go profoundly deaf anymore. And they have advanced disease. So there's plenty of options out there. There's a few options out there with genetic or manipulation of hair cells to get them to regrow. But most important is to recognize the hearing loss. If you think you have it, get it evaluated, see the degree of it, and early treatment. And with that, I'd like to turn it over to our next speaker.
If I may say at this point, Todd, I think it's an excellent talk that you have. You gave us so much insight into the ear problems. I mean, I as a pathologist don't see much of the ear pathology given to us. Normally we see the pathology from other organs and other sites, but the ear part we don't see it much at all. And so I think you gave us some insight into a very complex organ. very important part of the sensory system that we have. Can you all hear me? Okay, good. So before we come to Brandon, would you mind if you open up a few questions at this stage to kind of digest what you just spoke to us? I mean, in my mind, my question that I have basically is that since we have three parts of the ear, the external, the middle, and the inner ear, and all we basically understand at the moment that if you do not have a proper hearing, just have the audiologist give you a hearing aid. But the way I understand now, I think it's much more complex as to whether all hearing loss can be amenable by the hearing aid alone, or what type of hearing aids are available at different types. I believe that might be useful for different types of hearing loss that you have. And before you even get to that, like if you first of all want to diagnose what your problem is of the hearing loss, is it the external ear problem? Is it the inner middle ear problem? Is it the hearing hair cell loss problem? Is it the cochlear organ problem, or is it the otosclerotic problem? So will the MRI give you all the answers to that thing?
Well, no. So you really need a history, physical exam, audiogram. That gives you about 85% of the answers. The MRI rules out the bad stuff, but the MRI typically is normal. And so, thank goodness, I could give you a whole talk on acoustic tumors and skull-based tumors. But the history, the audiogram, the diagnostics that audiologist does, those are the most important, and physical exam is important as well. And then we augment our diagnosis with CAT scans sometimes for the bony anatomy, and of course the MRI to rule out things like acoustic tumors and other things. And the reason you don't get any pathology is the reason why our science hasn't progressed, because the pathologists usually progress science dramatically in areas where you can get a lot of pathology and study that and research it. But when you can't go in and biopsy the inner ear very safely, and unfortunately, like other organs that you can. So that was a good point you made.
Yeah, normally we see acoustic nerve tumors. Those are kind of the things that we see, or some infection-related stuff from the external ear, or some subcutaneous sebaceous gland obstruction, things like that. We usually see some biopsies of that. I think.
Subhash, I have one question for Todd.
Yeah, please. Yes.
I thought after ruling out the acoustic neuroma for Meniere's disease, what causes Meniere's disease and what causes a buzzing sound?
Sure. Well, so Meniere's disease is a fluid balance disorder in the inner ear. I briefly showed the three fluid spaces, and the homeostasis can be injured. It's the endolymphatic space that kind of swells with fluid, causing a fluctuating hearing loss and then intermittent dizziness. And the short answer is we have no idea what causes Meniere's disease. And the more you research it and the more you learn about it, the more you know we have no idea what causes Meniere's disease. There's all sorts of theories. The ones that make the most sense tend to go back to obstruction of the endolymphatic duct, which is a small duct I didn't talk about today that controls that fluid balance. And that can be blocked by either loose crystals, inflammation, trauma. But the short answer is we don't know. And the tinnitus, the short answer for what causes the buzzing sound is the buzzing sound in Meniere's disease is the same sound that, well, it sounds a little different because it affects different frequencies, but it's called tinnitus. And tinnitus is usually associated with hearing loss. Your brain likes to hear sound at all frequencies all the time. If it does not, because of an ear problem, it will make up sound in those frequencies. It feels like it's not hearing in that range because it's not sensitive enough, so it will increase its sensitivity until it hears it. And then that's even worse in patients with any type of anxiety disorder or situational anxiety, because your fight or flight system makes the tinnitus louder. But tinnitus is almost universal with significant hearing loss. It's a very common issue.
Yeah. Somebody grows out of it?
I have a question, Subhash.
We'll come to it. We'll come to it. Please let Ved finish.
Todd, my question was, is it a self-limiting? Sometime one can grow out of it? And it's a very disabling disease in terms of balance and dizziness.
And you're referring to Meniere's disease, is that right?
Yeah, yeah.
Okay. So the answer is yes, but the natural lifespan of Meniere's disease averages 15 years, and nobody wants to wait around to grow out of it because it can be horribly disabling. The vertigo spells, the intermittent vertigo spells are really disabling. In fact, most patients don't even care. They've lost interest in their hearing because they're so sick from the dizziness. And so the treatment for Meniere's is there's lots of treatment for it. You do not have to live with the dizziness. So for Meniere's disease, we have all sorts of treatments and certain medications, medical management, lifestyle changes, followed by multiple different procedures, steroids, and there are dramatic surgeries we can do too, where we'll just separate that ear from the rest of your brain, so you won't get dizzy anymore. We usually don't have to do that, but you don't have to live with the dizziness.
Thank you very much. Great.
Yeah.
And we will come, I think we have a few questions coming up. We'll come to all of them. One question that I have early on, maybe it should answer some questions that people might have also. The way you go to the eye site for regular eye checkup, would you go to the hearing audiologist or a ENT surgeon for a regular checkup on your ears or the hearing? And so is there something that you would, I mean, I know you mentioned about the tuning fork testing on your conduction system and all like that. And once you have the hearing loss problem, is it progressive and what gets worse? So what kind of preventive measures would you do to prevent the hearing loss from happening in the first place and from getting it worse in the second place?
So as far as monitoring, the answer is yes. I think you should get hearing screens to determine what your level of hearing is, probably starting around age 50 to 60 for men and 60 to 70 for women. Probably 60 would be a good rule for both sexes. And because early identification and adoption of technology to correct that makes a big difference. There's been multiple papers on the association of hearing loss and dementia, which probably are just coincidental. But there's some concern that hearing loss can contribute to dementia. And so early identification is important. As far as like, if you have a normal hearing test, I would maybe every other year instead of every year, like you would for an eye doctor, but every other year is probably adequate. Brandon might have some comments on that, but I do recommend that. I'm sorry, the second part of the question,
would it like get worse if you have a hearing loss early on? Would it get worse over the years?
Well, that's variable. Typically it does. It typically progresses. It progresses at different rates in different patients, even presbyocusis, age-related hearing loss. The average is about 1 to 2 decibels of hearing loss per year. I have seen multiple patients that will have progressive hearing loss for about 5 to 10 years, and then it stabilizes. I have patients where they have rapidly progressive hearing loss. And so it's hard to predict, but on average, yes, it does get worse with it. It's just the nature of presbyocusis. That specific diagnosis.
Because the incidence that you mentioned early on was like 50% of people 75 and above have this hearing problem loss, which is a serious kind of a very high incidence that we have according in the old age people that way. We have a question from Arun Jatkar. Arun?
I have actually 2 questions. One is, if you go to any pharmacy, there are lots and lots of earwax removal kits. Are they safe to use for children and for the adults? And secondly, if you have a cochlear implant, in the process of doing that, are you likely to damage your balance by somehow damaging the semicircular tubes?
Oh, good questions. So earwax removal products are safe if you do not have a hole in your eardrum. So if you don't have a history of chronic ear disease and problems, they're safe to use. They're not as effective as we want them to be. They emulsify the wax, they won't dissolve it, they soften it so your body can maybe migrate it out. They work well for mild cerumen impactions, but usually by the time someone's buying this product, their ear's tightly impacted, so they're not very effective. Anything that can dissolve cerumen, earwax can also dissolve the cells of your body. And that's why products haven't been invented to dissolve earwax, because they're dangerous. But the ones that are out there are safe. They're just not that effective. So, and for cochlear implants, it's a common issue to get some imbalance about 30% of the time. You'd think it'd be 100%. But research has shown that about 30% of the time, when you're inserting a cochlear implant, because you're affecting the fluid space that's shared with your balance system, patients do get increased disequilibrium. We're very fortunate in that most of the patients have very plastic systems, meaning that you can compensate easily for it. It's very, very rare for any of my patients who have a cochlear implant to have a persistent balance problem that they didn't have before the implant. It's usually a temporary phenomenon.
Thank you.
I have questions, Subhash.
Okay. 1 second. I think we have a Yugendra Gupta. Yugendra?
Yes, can you unmute me? Yes,
You are-
Dr. Rahman, it's
We
very,
can hear you. We
very
can hear you.
good educational talk. I have a question for you.
Yes.
There is a loss of hearing in only 1 year. Why is that happened? And if that can be improved by using hearing aid, or hearing aid is not good at all. If so, I mean, this last 1 year loss, I can experience this myself every day. So why that happened?
So loss of hearing in 1 year is sometimes difficult for us to explain. But when it occurs suddenly in 1 year, or even if it's just slowly progressive in 1 year and not the other, those are the patients that we really like to get an MRI scan on. Only about 1 in 50 patients with unilateral hearing loss or single-sided hearing loss will have a acoustic tumor, but that would be the kind of thing that we would want to do. Most of those MRIs are going to be normal, and then unfortunately the reality is that we don't understand why 1 ear can go bad whereas the other one doesn't. The other thing with unilateral hearing loss is that there's a higher incidence of conductive hearing losses in those patients. So they think they have a nerve loss or age-related hearing loss, but it often can be a surgically correctable problem. So if it's, it can be one extreme or the other. It can be this acoustic tumor thing, or it can be something that's surgically correctable, an ear bone issue or an eardrum issue. So unilateral hearing losses should almost always be evaluated by a physician who specializes in ear care. And most of the time, yes, hearing amplification still helps if there is word discrimination ability, if there's some clarity. And that's determined by the hearing test, the audiogram.
Yeah.
So
then-
the hearing aid, hearing aid can help not a further loss to the.
Well, hearing aids don't prevent further loss, unfortunately. They prevent further loss in your central auditory system, where your brain is interpreting that sound. And we take the central auditory system for granted a lot of the time. So it keeps your brain auditory system active. So early adopters of hearing aids, for instance, like I have patients who've lost tremendous amounts of hearing. They're profoundly deaf, but they still do pretty well with hearing aids because they got them right when they started having hearing loss. And then I have patients with very mild losses that have lived with that for 20 years, and we put hearing aids on and they don't help. So it can prevent, but it doesn't prevent the ear from going bad. It does prevent further loss in your central system. So early adaptation is important. So the answer is yes, improving hearing loss in a patient with hearing loss just in 1 year it's still important.
Is any kind of surgery required?
Well, it depends on the cause. And so you saw that huge long list of different diseases that can cause hearing loss, and sorting through that's is usually done best by an examination and a hearing test.
Okay, thank you.
Oh, you're welcome.
Remind everybody that we still have a third part of the talk by Brandon Levine coming up still. And we just have 3 more questions we'll take, and then we'll come to Brandon after that. And then we'll still open up for more Q&A a little later on. Dr. Popot had a hand raised earlier. Dr. Popot?
Well, I just wanted to make one comment and one question, because it was an excellent coverage of components of the ear. My question, genetic interest, was what source of pluripotent cells do you draw on? Number one. And number two is, are these cells that you draw on homologous or heterologous, does it matter?
So I'm behind on the state of art of the stem cell research, but there's most of the success that has been done in the country has come from adult stem cells. So the source is autologous. Yeah. So they're either bone marrow or blood derived. And those seem to be obviously the most well tolerated. In animal research, if you're using stem cells from other, even within the same species, they don't last very long. There's a lot of interspecies work as well that doesn't last as long. But the most potential in my mind is adult stem cells. Now, so a lot of the research has gotten away from stem cells in the last 5 to 10 years and into cytokine modification of existing cells, because you can generate hair cells in the lab, but getting them into the cochlea in the right spot is very difficult. We think in theory it's easier to manipulate existing cells to revert back to stem cells and then go into hair cells, the supporting cells in the cochlea. So the research has really turned. Honestly, hearing loss is underfunded, and as a result, it's moving too slow in this country. But that's my opinion. It's really only a few researchers in the U.S. that are adequately funded to do this, and so for such a common problem, you would think it would be more, but it's not.
We'll go to Dilip Desai.
Yes.
Dilip.
Yes, I have one more question for you, Dr. Hillman. So let us say the age-related hearing loss, which is kind of progressive over the years. Are we saying it's irreversible? It cannot be reversed? Is there anything that can be done to reverse first, or maybe they stop further loss and then possibly reverse it?
So unfortunately, presbycusis is not reversible. So right, there are some nerve losses that are, but they tend to be like with the Meniere's and or sudden hearing losses, but not presbycusis. Stopping the progression seems to be that anything that stops the progression of anything to do with microvasculature issues, like anything that prevents strokes, anything that helps your kidneys, that helps. So just general good lifestyle, control of hypertension, avoiding tobacco products. Those are the most important things. Noise exposure can, although most fortunately in the modern world and then post-industrial world in the US, most people are not exposed to continuous occupational noise that creates hearing loss, but that can, in some individuals that can be an issue. But just general health, there's no magic cure. There are some studies being done on, antioxidants. There's been some success with red wine derivatives, resveratrol, to prevent further hearing loss. You'd have to, and so that might be a reasonable supplement, resveratrol, I think it's called. But no, it's not reversible. And general, whatever keeps the rest of your body healthy does keep the ears healthy. It's kind of the general.
Thank you very much.
Thank you. Yeah.
Okay, we have one more question to go, then we'll go to Brandon after that. Dr. Luthra?
Selective.
have,
Is there any
Wait, Dr. Luthra has some questions. After that, we'll go to Brandon Levine.
Just have a comment and a question. Question is the whooshing sound in one ear can become disabling. Is there any solution to that? And secondly, the removal of wax using a Q-tip should be not done, because I had done that myself and pushed the wax against the drum. So that was just a little word of caution. But more question was about the whooshing sound. Can something be done to?
So yeah, is the whooshing sound your heartbeat or is it a tone?
My wife, she has in one ear, she constantly hears psh, 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 that kind of sound.
So that might be a different type of tinnitus called pulsatile tinnitus. If it's coincident with the heartbeat, that is definitely a person that should get a medical evaluation. Usually it's benign pathology, but it can be treated. If we
She's had MRI scan done and that was negative.
So if it is a heartbeat, if it's coincidental with a heartbeat, like a whoosh, whoosh, it's not a tone or a whooshing sound, then an MRI is helpful to rule out a few things, but also I would do a CAT scan. I would also do angiography, and then I'd actually have a neuro ophthalmologist to see if there's an increased pressure in the brain balance fluid, in the brain fluid, in the spinal fluid. So the workup of pulsatile tinnitus is much more complicated than regular tinnitus. But the good news is there's usually a cause. Not always, sometimes we can't figure it out, but usually there's a cause that we can target and treat. Right.
All right. Now, with that, I think Brandon is an audiologist that we have. His important part of as to all the problems that have been discussed, how do we fix that problems is Brandon's specialty. And so we invite Brandon to give us some insight into the audiology part of it, all the hearing aids and all things that we use. Brandon, please enlighten us.
Right. Good morning, everybody. Let me share my screen here. Let's do that, and I want to do this PowerPoint presentation. Let's share. There we go. Let's get it full screen here if we can. There we go. All right, so we will talk a little bit about hearing loss. So first, just a little bit about me. Here's a picture of me and some of my family. So I am an audiologist. This was at somebody's wedding or a bar mitzvah or something. So we got my dad, my mom, my sister-in-law, my brother. I'm missing some nephews and a girlfriend. So I got in trouble for not putting those pictures in, so I apologize. But just a little bit more about me. I am from the Pittsburgh area. I grew up in the South Hills and graduated from Upper St. Clair. Did my undergraduate degree at Penn State, and then I did my graduate work and got my master's and my doctorate in audiology at the University of Pittsburgh. So now I am actually a working audiologist. I work at an ENT practice out in Fox Chapel in RIDC Park with Dr. Suman Gola, and our practice is Gola ENT. So we were going to talk a little bit more about hearing loss. So also bear with me. I just moved into a house on Friday, so I just moved here and my Wi-Fi wasn't working, so I'm running a hotspot through my phone. So if I jump out at any point, I'll try to jump back in real quickly, but hopefully everything's okay. So hearing loss, a little bit of background that both Dr. Malapati and Dr. Hillman presented on. Just hearing loss can actually affects 466 million people worldwide, some form of hearing loss. Approximately 1/3 of the individuals over the age of 65 have some form of hearing loss. And as the statistic was discussed by Dr. Hillman and Basu, that number actually increases to about 50% after the age of 75. So some common consequences of untreated hearing loss, those include first and foremost communication difficulty. If you can't hear the person you're trying to talk to, it's going to be awfully difficult to have a conversation. This can actually lead to isolation and a frustration, and actually sometimes the person with the hearing loss dominating the conversation using a known topic just so they don't get lost at any point within the conversation. Obviously, if you're having difficulty talking to some people, you can withdraw from these conversations, withdraw from family gatherings, conversations with friends, meetings, and that can lead to a lot of anxiety and depression. So it's something we want to try to take care of. So some good signs of hearing loss: if you or a loved one starts noticing these things, it might be time for an audiologic evaluation. So first and foremost, somebody saying what or to repeat yourself constantly. Obviously, if someone says that once or twice, that's okay. But if it's something that you're noticing more and more, it might be something that you want to address. A lot of times what I hear from patients in the clinic is, I can hear, but I can't understand. And that really goes back to exactly what Dr. Hillman was discussing, that hearing loss is dynamic. It is not static across all the frequencies. We don't typically see a flat hearing loss, although we can, but most of the time it is dynamic. So we're taking out those keys of the piano, and that can make the whole meaning of a sentence change sometimes. We miss part.
You will come back, huh, babies? Problem છે ને નવા હાઉસમાં મૂવ થયો છે, વાઈફાઈ નથી.
I will stop it.
We can't hear.
I think we're having some technical problem over here, Brendan. We stopped hearing from you.
Sorry, I think I'm back. Sorry, that was the whole hotspot fiasco. So let me get back into my screen here. There we go. So sorry, bear with me. Let's get this back up here. This is good. There we go. Okay. So another one, like Dr. Hillman had discussed, difficulty hearing and noise. This is something hearing aids have gotten better at dealing with, but this is just something that's part of the normal aging process, that we lose that ability to process speech in the presence of background noise as well. Like I did say, I mean, hearing aids are getting better at this. However, it's still one of the biggest complaints. You could have someone that is, let's say 85, has completely normal hearing sensitivity, but still reports that they have trouble in background noise, and that can just be part of the aging process. And then finally, another good sign is constantly asking for the TV or the radio or whatever you're listening to be turned up.
Redon, 1 minute, we lose your screen. Can you reshare your presentation?
Oh, yes. Let's do a new share.
And I can see the presentation.
Yeah, we can see it.
Yeah.
Okay. Visible?
Yeah, we can see it, Brendan.
Okay, good. So some common things that can be linked to hearing loss. And on this page, I always stress that these are things that can be linked to hearing loss. They don't necessarily, hearing loss doesn't cause any of these things, but there has been found to be a known association. So like Dr. Hillman had talked about, dementia and cognitive decline, they've been doing a lot more research, and when we don't have that same stimulation through the auditory pathway, they have been finding some relationships between hearing loss and these different conditions. There's also an increased risk of falls, just because you're getting unequal input sometime, or a lack of input to the ears. And then there can also be a known association between hearing loss and diabetes, heart disease, kidney disease, all going back to a reduction in blood flow to the inner ear. Let's see here. There we go. So types of hearing loss, I'm actually going to skip through this portion just because Dr. Malapati and Dr. Hillman did such a good job about talking about these different areas of hearing loss already. Some causes, there can be genetic causes, whether it's something, I'm not sure if this is what Helen Keller had, but there's a specific genetic mutation syndrome called Usher syndrome that actually causes hearing loss and blindness. So this could be a cause. There's also acquired causes of hearing loss. So that can be too many, like my dad, too many Bruce Springsteen concerts, and so a noise-induced hearing loss. There can be infection, so fluid in the ear. There can be wax in the ear that causes hearing loss. Complications for children with hearing loss can be low birth weight, infections during pregnancy, or severe jaundice. Like Dr. Hillman and Dr. Malapati already said, medications can cause this. So chemotherapy, high doses of cisplatin or high doses of aspirin can a lot of times cause high frequency hearing loss accompanied by a high frequency tinnitus. And then most commonly, aging. So age-related hearing loss, or presbycusis, is the most common type of sensorineural hearing loss. It occurs when there's a deterioration of the hair cells in the basal end of the cochlea. So if we look at the cochlea over on the right side over here, it kind of looks like a snail shell. It is called tonotopically organized. So all the high frequency sounds are encoded on the outside of that snail shell. All the lower frequency sounds, low pitch sounds are encoded on the inner portion of that. So most commonly, presbycusis affects those high frequencies. So if you actually look down at the bottom, these are a picture of those inner hair cells that function. So when we hear sound comes through the ear canal, vibrates that eardrum, pushes some fluid through our inner ear, and that's what vibrates those hair cells. So when we've got the good healthy hair cells, they vibrate, fires a neuron, sends the signal up to our brain. That's how we hear. What's going on with presbycusis, or that age-related hearing loss, is those hair cells, instead of standing up nice and straight, they start to look like blades of grass that have been stepped on almost. So that fluid gets pushed through, and that signal's compromised because they're not transducing the same way. So like Dr. Hillman had reviewed, this is a typical audiogram for someone with presbycusis. As we can see, just for your reference, circles are the right ear, X's are the left ear. We test, if you look at the X-axis up top, we test like keys on a piano from low frequencies to high frequencies. And we test from on the Y-axis from soft sounds to loud sounds. So this person's audiogram would be pretty good low frequency hearing loss, sloping to about a mild to moderate high frequency hearing loss. Now, an audiogram is separated into two parts. So this part that we just reviewed, that shows us really the hearing sensitivity. So how well someone is detecting sound across the frequency range. But what's also important, especially when we're considering amplification and its success in amplification, is our speech testing. So one of the tests we do is called word recognition. And during that test, that would be a portion of the test where we would play the phrase at an audible level, and we would play the phrase, say the word, and the patient would repeat the last word of that sentence. So in this audiogram, the patient scored 92 and 88% in that word understanding. That's excellent. So that patient would be a pretty good candidate for hearing aids, because really, as long as we're making things loud enough, they're still understanding and processing that sound very well. Where we can get into a lot more trouble and a lot more difficulty with hearing aids is, let's say somebody has this exact same sensitivity to sound on this portion of the test, but if we move up to that speech understanding, their word understanding is down at about 40 or 50%. If that's the case, a hearing aid can make things louder, it can make them more audible and more sensitive, but it does not help in clarity, because it is all a hearing aid is doing is it's putting sound into a system that has damage. And that's why a hearing aid is a great solution, but just as the word entails, it is a hearing aid. It is not a hearing corrector. So someone with much better word understanding scores is going to be a lot more successful in a set of hearing aids. If someone were to have low word understanding, kind of depending on what's going on, we would still recommend a hearing aid, but we have to be as upfront as possible and really counsel the patient that the hearing aid will make things louder, but it's not necessarily going to make things any clearer. So, and that goes back to this phrase. This page was just setting those realistic expectations with the hearing aid. That's one of the biggest parts of my job when I do discuss hearing aids with patients is I like to be as upfront as possible. I want to set those realistic expectations. Hearing aid does a great job of making things louder. And a lot of patients, if you have that good word understanding, you can be very successful, but it is something that takes time to adapt to. And that's something that also goes back to wearing the hearing aids. If you have a patient that doesn't comply with wearing their hearing aids, they're not going to be as successful. So if you have a patient that puts their hearing aid in, takes it out, puts it in, takes it out, they never give their brain a chance to adapt to hearing through the hearing aid versus hearing through the hearing loss. And those are going to be the patients that have a lot more complaints about their hearing aids, because they simply haven't given their brain a chance to adapt. And like Dr. Hillman was talking about, the brain has plasticity, and the more you wear the hearing aids, the quicker it adapts. So what are our treatment options if we do have hearing loss? So one of the big things right now are personal sound amplification products, or PSAPs. There's also different, if you didn't want that, there's also different assistive devices we can use depending on what situation you're in. If you get to those profound, severe cases like Dr. Hillman discussed, where there is a cochlear implant, and then most commonly are hearing aids. So a little bit more about those personal sound amplification products, or those PSAPs. This is what's often referred to as the over-the-counter hearing aid. And I put hearing aid in quotations because it's not necessarily really a hearing aid, more so it's an amplifier. So this type of product is usually on the cheaper end of things, usually around maybe $200, something like that. And sometimes it can be very good for a mild hearing loss. But a lot of times hearing loss is a lot more than mild, and hearing loss is dynamic, like we talked about. So why this hearing aid sometimes isn't very effective is because of that dynamic nature of hearing loss. So if I go back to our slide here with the audiogram, what an amplifier or an over-the-counter type of hearing aid does is it uses what's called linear amplification. It is going to amplify everything at the exact same level. Some of the newer over-the-counter type hearing aids can sometimes adjust differently for lower frequencies or higher frequencies, but for the most part, they are just general linear amplifiers. They're going to amplify everything at the same level. So let's say this over-the-counter hearing aid is amplifying everything at 40 decibels. When you get to those lower frequencies, it's going to be over-amplifying that sound. When you get to the middle, it might be just about right. And when you get to those higher frequencies, it's going to be under-amplifying those sounds. And that's why a lot of people sometimes don't like it. However, if you have a patient that has a very mild and pretty flat hearing loss, this type of over-the-counter hearing aid is a very good option. So let's see, next we will go to some assistive devices. So first, there are remote mics. So this could be something like a pocket talker, or even now with hearing aids, actually, you can connect the hearing aids to a cell phone via Bluetooth on a lot of them and use the same type of feature straight through your phone. So this type of remote mic, what this is good for is, let's say you're really trying to listen to one person. It's essentially a microphone that is connected to a headset. The patient would wear the headset. The person you'd want to listen to is wearing that microphone, and it just is an amplified signal to that headset for the patient with hearing loss. Next, there is also an option for the TV. So one of the biggest ones and most common are TV ears. Now, there are products for hearing aids as well that could connect to your TV, but if you have a mild loss, you really only want something to help you out with the TV so you're not blasting or drowning out anyone else in the room by turning the TV up too loud. Something like this product, TV ears, is a very good option, and it's available on Amazon, easy to set up. It's something that plugs into the back of the TV, and it sends the signal to the headset that you would wear via Bluetooth. And that way it doesn't affect the volume for anybody else in the room that wants to listen to the TV, but it can amplify it for the person that wants to listen. Next, there are FM systems or infrared loops that you can set up with hearing aids, or even not hearing aids. You can set them up just for speaker headset systems. So with this, this is commonly used in large venues, or let's say a lot of times places of worship have these. So I'm Jewish. My synagogue uses an FM system. My grandpa has hearing loss, so he uses the FM system whenever we're at services. So essentially, it's just a microphone that the speaker uses. It would be kind of like just a radio signal. It's an FM signal that would be attached to either a neck loop or some sort of device attached to a set of headphones. And that way you can get a direct signal right from the speaker or the leader of the congregation. This is a very good option if all you're trying to do is listen to the leader of the congregation. However, if you're trying to listen to other people in the congregation, if they're talking, it's going to be difficult because it's only amplifying who's ever speaking with the microphone. Finally, we've got closed captioning. So this is very common and a very good assistive device and solution for the TV. If you're having difficulty hearing, it always helps to have another form of input. So closed captioning on the TV is great. But what also we have is there's closed caption telephones. So if any of you do see an audiologist or a hearing aid dispenser, you can always ask them about this. So the picture I used here is actually called a caption call telephone. And this is a great product because it's a free government program. So you would tell your audiologist or your hearing aid dispenser that you are interested in a caption telephone, you're interested in caption call. Me as the audiologist would register you for this program, and it's a free government program. The company would come to your house, install the phone, teach you how to use it, and it would caption your phone calls, it would caption your messages, and it's a great program. So the big one though, what most people use for hearing loss are hearing aids. So this is a very good example of the traditional, the most popular kind of style of hearing aid right now that Dr. Hillman was talking about. This is called a receiver in the canal hearing aid. So it's just a small piece that goes right behind the ear, and then a small wire that would run in front of the ear. And that's actually the speaker that would be inserted right into the ear canal. So different parts of the hearing aid. There is the microphone. That's what actually sits kind of in the back at the top of the hearing aid. And nowadays, most hearing aids have two microphones at least. One is typically a fixed directional microphone, and the second one is usually an adaptive microphone that can kind of try to pick up where speech is coming from. Next, there's the amplifier. So that's what's actually housed in the main unit of the hearing aid. That's where all the good stuff, that's the computer of the hearing aid essentially, that's going to amplify that sound. There is also a volume control, and that's the little toggle switch at the bottom of the hearing aid. So you could turn it up or down depending if you needed that for the situation. However, I would say as long as the hearing aid is properly programmed, most people typically keep it in the default level of volume, I'd say about 90% of the time. That volume control can look different depending on what type of hearing aid you have. So on this image that I'm using, it's a little toggle switch. Some of them can be a push button where one side would raise the volume, the other side would lower it. There can also be a little volume wheel if you wanted to turn it up and down. Just depends on the type of hearing aid. Next, as we move up, this thin little wire that attaches to this little piece that goes in the ear, this is actually the receiver of the hearing aid or the speaker of the hearing aid. So with this style of hearing aid, it's called a receiver in the canal because that speaker is going directly into the ear canal. And like I was saying, this is right now the most popular style of hearing aid. It is typically the most popular style because if you look at the very end, there is a little rubber dome on the end, and this is typically a lot more comfortable than wearing an ear mold or a custom product that's a hard piece of plastic sitting in the ear. And the dome actually allows us to do a couple different things based on sound quality, but I can touch on that here in a minute. Next, underneath that little dome is a piece called a wax trap. That's going to prevent any wax from getting into the speaker or the receiver of the hearing aid. It's a great little invention. However, if it plugs up, it's going to make the hearing aid sound like it's not working at all because it's going to block that sound from getting through. Luckily, it's an easily changeable piece, and it really does protect the housing of the speaker of the hearing aid so it doesn't damage any of the internal components of that speaker. Finally, there is the battery door or the charging port. So battery door would be right at the bottom of this hearing aid. It can be right on the side if it's a custom hearing aid, but a lot of the hearing aids now, especially in this receiver and the canal style, are actually rechargeable hearing aids. So all you would do is drop it into a little charging case and the connection would be right at the bottom of the hearing aid. So next, benefits of treatment, of getting something. So first off, better relationships. If you and your spouse aren't yelling at each other from other rooms, I will take that as a positive. That is a good sign. That is things are going well. So better relationships just because you're better able to communicate. This also goes for, I would guess, my grandpa has his hearing aid, and he always says, he showed me when he got his latest one, he goes, here, look at this, I've got a button right on the back. So your grandma starts yelling at me, I hit this button and then I can't hear her anymore. So there's also that type of feature as well, but hopefully we don't need that. Next, hearing aids improved cognitive health. So just like Dr. Hillman was discussing, having a hearing aid and having some form of amplification just keeps that auditory pathway stimulated. Next, happiness. So, I mean, the better able you are to communicate with loved ones and friends and colleagues, the more happy you'll be, I guess, depending on the person you want to communicate with. And then finally, improve self-confidence. So just giving you the peace of mind that if you do go somewhere, if you do go to a meeting, we don't have to worry about being embarrassed that you can't hear someone or not want to engage in the conversation in case you miss something. So just an improved sense of self-confidence. These are some of the major manufacturers of hearing aids. I just wanted to kind of show a picture just so you could see what they are. So these are my practice goal at ENT. We work with any of these manufacturers, but these are about the 5 main companies of hearing aids. So hearing aids come in all different shapes and sizes. If we look at the left side of this column, we've got custom hearing aids, in the ear hearing aid products. We go from small to large at the bottom. What we choose for a patient really depends on the hearing loss. Custom hearing aids are very nice. We would take a custom impression of the ear canal and they would be custom molded to your ear. These smaller size ones are good, but they do have their limits depending on how small they are. We can't necessarily get all the amplification we need if someone has a more severe hearing loss. As we go up in size, we can get more and more power into the hearing aid, as well as some more connectivity features. Right now, rechargeability is not readily available in these custom styles of hearing aid. There is one manufacturer that is making a rechargeable custom product. However, it's only available in the largest size. On the right side of the column here, this is traditionally what people think of if they are thinking of a hearing aid. It is a behind the ear instrument. So this top column here, this top one, the behind the ear hearing aid, this is what most people think of. It would be connected to a tube and an ear mold. It'd be pretty big. This is really only necessary for the more severe hearing losses if it's across the entire frequency range. What most people are doing nowadays is using this receiver in the canal style. So it's a much smaller piece that goes behind the ear, just that thin wire that honestly, unless you're looking for it, you can't really see it. And just that receiver that goes in the ear. And why this is great, especially for an age-related hearing loss where we have that very good low frequency hearing and we really only need the amplification for those higher frequencies, is we can do what's called an open fit with this type of style. So that little rubber piece that goes on the end will actually have openings in it, and that allows the low frequency sounds that you're hearing well to pass through the ear naturally and really only amplify those higher frequency sounds that we need to amplify. Any of these styles of hearing aids are very good products, but if we were to do a custom style or something with an ear mold for that patient that has the good low frequency hearing aid, it closes up the ear and we then have to amplify those lower frequency sounds. So it is still working very well. It's just a little bit less natural of a sound quality. So next we've got the processing of the guts of the hearing aid. So there is analog hearing aids versus digital hearing aids. Analog are the earlier type of hearing aids, probably everything since I'd say 1995 to 2000 is more in the digital realm. Analog are the older ones. And the analog hearing aids are actually pretty similar to the over-the-counter hearing aid that you'd get now. It's more just an amplifier that's amplifying mainly everything linearly. With some of the analog hearing aids, they did actually give you like about 3 channels or 3 frequencies you could tune from. But nowadays we've got digital, which gives us way more ability to program the hearing aid and fine tune it to each frequency. Like we discussed before, hearing loss is very dynamic. So we do need that ability to fine tune at each frequency to best fit a patient's loss. What hearing aids also have nowadays is called wide dynamic range compression. And essentially the goal of this feature is to amplify the soft sounds where you need the most amplification. So something very soft and quiet like a whisper, we need that to be amplified more than if someone were shouting and it were to be very loud. So the goal of this compression is we're going to amplify the soft sounds the most, and we're going to compress the loud sounds that don't need as much amplification. So that fits a person's speech into a dynamic range, and it gives the patient a more natural sound quality. Finally, hearing aids nowadays have different types of microphones, directional microphones. So these microphones are adaptive and they can automatically direct to where the signal is occurring. And because they have multiple microphones, you can actually have 2 microphones in different settings to pick up kind of what the environment calls for, what the environment needs. So you could have, if you were in a crowded area and you're trying to talk to the person in front of you, those microphones can be switched to be directional in front of you and try to pick up what's in front of you and try to cut out what's behind. So some features of hearing aids. First is noise reduction. So this is something that has definitely gotten better, but by no means I'm going to say it's a perfect solution. Like we discussed earlier in the presentation and like Dr. Hillman discussed, hearing in the presence of background noise is still the biggest complaint with or without hearing aids. It's part of the aging process. So what noise reduction really tries to do is it evaluates the microphone, and the hearing aid evaluates the spectral signal of what's going on. So typically noise is a very static symbol or a static signal that's very consistent because it's a steady state noise, versus speech, which is very dynamic, and we have different inflections and different tones. So what the hearing aid tries to do is pick up what is speech versus what is noise, and it tries to reduce the noise and keep the speech amplified. However, I will say this has gotten better, but sometimes what can happen, and if you have hearing aids, you might know this, when this noise reduction kicks in, a lot of times it can also reduce the speech as well. So it's something that is getting better, but it is by no means perfect. Also, Dr. Hillman had discussed feedback management. So that can allow us to have these open fits so that the hearing aid doesn't whistle or feedback. So the biggest cause of feedback, or that whistling noise that you would hear with a hearing aid, really is improper fit in the ear. If the hearing aid is properly seated in the ear, it really shouldn't whistle too much. But that's where newer hearing aids are doing a much better job, because they have automatic features that pick up on this whistling and try to eliminate it. Next, the newer hearing aids, especially those little ones that go behind the ear, have rechargeability, so you wouldn't have to deal with batteries or anything like that. Most of the hearing aids hold about 24 to 30 hours per charge, depending on if you have them connected to a cell phone. If it's connected to a cell phone and you're using streaming and things like that, it's closer to that 24-hour range. If you're not using any sort of streaming and just using the hearing aid, they really hold that charge for about 30 hours. Another nice feature is portable charging. So some of the cases nowadays actually, they would still be plugged into the wall, but the case itself can actually hold a charge for a couple of days. So as long as the case is charged, you could put the hearing aids in the case and they hold about 3 days worth of charge. So you wouldn't have to have it plugged into a wall to charge your hearing aids. Some of the cases also have dehumidifiers in them. So that's a nice feature, especially because what can definitely cause the breakdown of a hearing aid over time is moisture. So these dehumidifying cases, when you'd plug them in at night before you go to bed to charge, you'd close up the case and they would draw that moisture out, and that actually helps elongate the life of a hearing aid. The biggest kind of development in hearing aids right now is Bluetooth connectivity. So that's been a fun feature to work with, and it's honestly the most readily available with an iPhone. They're getting better with Android phones, some of the newer ones, but really to get the full use out of it, I would say iPhone is the best for hearing aids at this point in time. What the Bluetooth connectivity allows you to do is essentially turn your hearing aids into wireless headphones. So it allows you to stream your phone calls to the hearing aids. It could allow you to stream your music to the hearing aids. If you were watching a video on an iPad or something, you could actually stream the volume right to the hearing aids. Even if you were driving in the car and you had your GPS up, it would say those GPS instructions right through the hearing aids. Another cool feature with this Bluetooth connectivity is GPS tracking or GPS location. So similar to if you ever lost your iPhone, there's a Find My iPhone feature. If you lost the hearing aids, there is a Find My Hearing Aids feature. So you can see right on a map where the hearing aids are, and hopefully you wouldn't have to use any loss and damage coverage to get a new one. Also, so these last two features I will mention, they are only available right now in one brand of hearing aid called Starkey, and it is their top of the line hearing aid. But they do offer real-time translation. So what would happen is you would have an app for the hearing aids. If someone were speaking, you could put it in this translation mode and it would transcribe onto your phone the different language that's going on. And I'm pretty sure you could actually, I'm not positive on this, but I'm pretty sure you can actually play back the translation into the hearing aids, into the language of your desire. They also, and some of them have fall detection. So if you have a loved one or a patient that is a big fall risk, the hearing aid actually has a fall detection feature on this hearing aid as well that would notify, I think it's up to like 3 contacts or 2 or 3 contacts if the person ever fell, and it would send them a message saying you might want to check in on this person and call, we detected a fall. So next are the mobile apps that can connect to all the hearing aids now. So when you have these Bluetooth, notice I have them all on iPhones just because iPhone, like I said, is the most readily available at the moment. But you can actually, all from your phone, you could change the volume of the hearing aid. You could change programs of the hearing aid. They even, some of them connect to an Apple Watch, so you could make volume changes to your hearing aids right through your watch. This is where you could also use other features and kind of fine tune the hearing aid depending on your environment. So depending on the hearing aid and depending on the app, let's say you were in a very noisy situation and you were picking up too much background noise, you could actually go into the features, and there's a feature called a sound enhancer, and you can actually lower your bass and raise your mids and your trebles. And that would actually help when you lower the bass. That takes out a lot of the background noise, or at least tries to take out that background noise. And the mids and the treble are trying to be, that's where that speech frequencies are. So you're really trying to raise the speech and lower some of that background noise. So it gives you more individualization, gives you more control over the hearing aid. And you can actually, if you really have a setting that you like after you've made those changes, you can save it right into the app and switch to that program whenever you want. Some of the hearing aids even have, gets a little creepy, but you can tag each program if you make those changes to a location. So let's say you made some changes to the bass and those trebles at your favorite restaurant. Obviously, once we can go back to restaurants regularly, and you can tag a location to it so that whenever you go into that restaurant, the hearing aid would automatically turn into that program, your restaurant program, as soon as it senses you're in that location. One other nice feature, going back to those remote mics, like we had discussed on assistive devices, it's a nice feature. So going back to that remote mic on the cell phone, this is a feature that is only available on the iPhone right now. But the hearing aid not only connects through an app on the iPhone, but it connects to the iPhone itself. And that's what's separating the iPhone from Androids at this point in time. So there's a feature called Live Listen that's very useful. Let's say if you're in a noisy situation, that you can turn on this feature on the iPhone called Live Listen, hand your phone to somebody, and it will stream their voice straight to the hearing aid. So it can really cut through the background noise. Or if you feel like being a little maniacal, you could steal your spouse's phone and pretend to be their inner conscience, but that's up to you. So I know I have gone through a good bit of information in a short amount of time. What questions does anyone have for me?
Yes, Brandon, that's a very, very nice talk that you had. Thanks for the enlightenment. I think it's excellent. I think everything is so specialized these days now. And I think it's good to hear from your business as what is available in the many, many features that you have in the hearing aids. So with all the features that you have, what would you say are the various range of costs? The more expensive, I believe, are the more features added to it, and that's why they're more expensive. Are these, and secondly, are these covered by the insurance?
Okay, so good questions. So to answer the insurance question first, most insurances, it is unfortunate, but most insurances do not have any sort of hearing aid coverage. There are a lot more insurances recently that have been having some sort of benefit or that have been partnering with a third-party provider. So one of those would be, there's a program called True Hearing. There's another one called Hearing Care Solutions, where the audiologist or the practice where you're getting the hearing aids from would have to be partnered with these third parties to get a discounted price on the hearing aids. But I would say for the most part, most insurances do not have any sort of coverage. Hopefully this is moving in a better direction, because just last year there was some legislation passed that Medicare, I believe in 2022, is going to start having some coverage for some severe hearing losses. But at this point in time, most insurances do not cover hearing aids. Now, going back to your first question, so the first part of the question on cost of hearing aids, that really depends on where you're going sometimes. So some hearing aid, I would say the majority of practices that sell hearing aids use what's called a bundled price model. So at Gola ENT, where I work, we use a bundled model, and that is the cost of the hearing aids, the cost of the fitting. So for my services and all the fitting and specialization, as well as all of your follow-up appointments would be included in that price. So the way we structured our services are, we would see you for the fit of the hearing aid. We would see you for a 2-week follow-up appointment just to check how things are going. And then we would see you every as long as everything's going well at that 2-week follow-up, we like to see you every 6 months for just a regular cleaning and check of the hearing aid. Because these hearing aids do get very expensive, we want to make sure they work as long as possible. So that's why we like to do these 6-month checks. And once again, since it's part of that bundled price model, there's no copays or anything like that at those 6-month checks. That's all included when you purchase the hearing aid. So as for ranges of prices, it depends on the level of technology that we put in the hearing aid. So the way I kind of like to describe it is I like to say the style of the hearing aid that we get, or the type of hearing aid, whether it's a custom or a behind the ear, that doesn't affect the price of a hearing aid. It's the level of technology that we put in it. So the type of hearing aid is kind of like the body of the car, and the level of technology that we put in it is the engine of the car. So what I will say, and that's where my recommendation on level of technology goes back to the patient's lifestyle. So this is where I usually tell the patient, what is your lifestyle like? They've done research between the 3 major levels of technology. Between all 3 levels, no patient reported difference in ability to understand speech. Where there is a difference as we go up in technology level is, like you were saying, more automatic features. It gives the audiologist more frequencies that they can tune at for a more personalized fitting. And it also has some more automatic features to try to help with background noise. So if I have a patient that really only wants a hearing aid for listening to the TV and listening to a spouse, one communication partner, they're not too worried about background noise, I would lean towards that entry-level technology probably. So our entry-level technology starts at $3,200. So I would recommend those entry-level hearing aids, and that's for the pair of hearing aids, that price. It wouldn't be for one individual, that would be for both. So I would recommend that entry-level technology. If you've got maybe a patient that still is very active, they're in noisy situations with background noise, trying to be in meetings and things like that, I would probably try to steer more towards that mid or high level technology. Although what I will say is they've done a lot of research with the highest end technology, and nothing has come back clinically significant or statistically significant that it is worth the price increase to get that highest level technology. And that's where I try to be as honest and steer my patients more towards that mid-level technology, just because there's a difference between an audiologist sometimes and a hearing aid dispensers, where dispensers might try to, honestly, they'll try to upsell you to that highest level technology. There's not enough that has been proven in research that there's benefit based on how much more you're spending for that hearing aid.
What would be the high end of the cost would be?
So at our practice, our entry level starts at $3,200. Our mid level goes up to about $4,500, and then our top level technology we usually sell around $6,000. I have heard of some practices, and it's really practice dependent what they set their prices at. I have heard of some practices for their high-end technology going up to $10,000 or $12,000. However, that's just kind of absurd.
Very well. I think we have a couple of questions that we have. I think Prakash Win had a question.
Yeah, let me see here. So for loss of speech discrimination in one ear, does it make sense to wear a hearing aid in that ear? So really, if you have a loss of speech discrimination in just one ear, it's a very tricky situation, honestly, to deal with. It's a very difficult amplification-wise. So there's a couple different options. So that's that single-sided loss that Dr. Hillman had discussed. What we usually recommend is it's really going to be trial and error sometimes with the patient. You can put a hearing aid in that ear that has the loss and discrimination, but really it would only be for sound awareness purposes, just so you can detect where sound's coming from. It would not help with clarity. There's also another option called a cross hearing aid or a bicross hearing aid. What that option is on the ear that has the loss of speech discrimination, you would wear a piece that looks like a hearing aid, but it's actually just a microphone. So it's going to pick up sound on that side and it's going to transfer it into another hearing aid on the other side that's a receiver and put all of that sound into your good ear. Now, I actually did a presentation on cross hearing aids when I was in grad school and on the satisfaction of patients with that type of product. And it is not always the best option for patients, just because, let's say, right now, as I'm sitting, I'm trying to listen to somebody on my bad side. So let's say my left side is my bad side over here. There's a speaker over here, and I'm trying to listen to them. It'd be great because the sound is going to transfer over to my good ear. Let's say I'm trying to listen to the person on my good ear, but out the window, there's somebody using a lawnmower or equipment, and there's a lot of background noise. If that's the case, it's going to take all that background noise and put it into my good ear. So that's where it's kind of a tricky solution. The other option is more invasive. It would be something like Dr. Hillman talked about, that BAHA or that bone anchored hearing device where you'd get that surgery. What that's going to do is essentially you'd put it on that bad side. It's going to vibrate the skull so you can pick up the sound from that side. But once again, it's really going to be that good ear that's doing all the work.
So in that case, with that technology, can you actually point which side the noise is coming from? Because that's one of the issues, like you said, you can't tell, you hear every.
Yeah, and that's yeah, and that's where it's tough. I mean, it's really how you situate yourself where the noise is occurring and if you want to use that or not. Sometimes in those situations, I would honestly just take out the cross portion because it is just going to pick up too much noise and put that all into the good ear. So that's why single-sided loss is honestly one of the trickiest to fit. I have a patient right now who kind of the solution we came up with for her was we did go with just a standard hearing aid in that bad ear just for sound awareness purposes. She's fully aware that she's not going to be understanding out of that ear, but really it helps for localization. So I find the best way to describe it is if we lose one eye, we lose depth perception. When we lose one ear, we lose the ability to locate where sound's coming from. So that's why sometimes we do just recommend a standard hearing aid, even though it's not going to help with speech. It will at least help localize where sound's coming from.
Thank you.
Okay, we have one more question from Mohan Suneji. Mohan?
I have a question.
Yep.
Okay, wait, let Mohan Suneji come up first and then we have Yugendra. Mohan?
Mohanji, can you unmute and can you on this video?
Yes, I just unmuted. So question is, there are several manufacturers, almost with same features. My question is, which is affordable, best manufacturers?
So as for most affordable, it really depends on the practice that you go to. So at our practice, even though each hearing aid manufacturer kind of sells us different things and such like that, we don't feel it's necessary to change our prices. So what we do is there's not really a most affordable one in the sense that any of the manufacturers we work with, we still stick with those same price points no matter which one we go with. So and then the type of hearing aid or the manufacturer that we want to go with kind of depends on the patient, because each company kind of has their strengths and weaknesses on what they do. So if we were going with a custom hearing aid, I would probably recommend the company Starkey, because they typically have a pretty good track record with custom products. If we wanted something, if we wanted that cross system that goes from one ear to the other, Phonak is typically the gold standard there. They have a very good product. If we wanted to go with connectivity features, we could do Resound or Oticon, or Oticon's actually been doing pretty well in background noise as well. So each company kind of has their pros and cons, and it's really going to depend on where you go. I don't know if other practices structure differently to make them more affordable, but we just kind of like to set a standard price to kind of choose what's best for the patient.
Okay, thank you. Do you have any opinion about the Costco sells Kirkland brand hearing aids?
Yeah,
Any
so I
opinion?
actually, yep, I saw that question earlier. So, so as for that Costco brand hearing aid, essentially what makes the Costco brand hearing aid less is because it's their own proprietary hearing aid. It's Costco's own brand of hearing aid, and that's what can help make that cost go down, as well as a lot of times, I don't know how Costco structures their follow-up visits and things like that. I don't know if you have to pay for follow-up visits or things like that, but it can also, that goes back to how the company or the practice structures their, how they structure their pricing outline. So one, the biggest thing that makes it less is just that it's their own proprietary type of hearing aid. And that's where it's difficult if someone were to come in with a Costco hearing aid into our practice. I don't have the parts or the ability to change things up or to program those types of hearing aids. It can only be used at Costco. Versus some of the major manufacturers, you can really go to any practice and they should have the ability to reprogram or give you parts and things like that.
Okay, thank you very much.
Jukendra Gupta. Jukendra?
Hello.
Yes, go ahead.
Yeah, hello. Dr. Brandon, thank you very much for this detailed information about hearing aid.
No problem.
My question is, are these hearing aids available at your office? If someone wants to come and visit you and do the examination and suggest which hearing aid he or she should buy?
Yeah, so what we do at my office is typically we would schedule you for an appointment to come in, and usually before we do anything hearing wise, we like you to see Dr. Gola. So Dr. Suman Gola is our ear, nose, and throat physician. So we'd like you to see her first, just so she can examine the ear, get any wax out of the ear, and make sure everything anatomically is looking okay. And then you'd see me afterwards for a hearing test. We'd go over the results of the hearing test, and then we could always do a hearing aid evaluation after that. So typically a standard hearing aid evaluation is about 30 to 45 minutes, just where we would talk about the hearing loss a little bit more, talk about the different types of hearing aids, and let you actually demo a hearing aid in the office so you could see what it might sound like, what it might feel like, just to give you an idea.
So these are available in your office, right?
Sorry, what was that?
These hearing aid devices are available in your office after you do the examination?
So we don't keep any stock of the hearing aids. So after we have that hearing aid evaluation and discussion where we kind of talk about what's the best option, depending on what we pick, I would order the hearing aids, and usually the turnaround time is about a week or two before we get the hearing aids in and we'd fit them.
Okay, thank you.
Yeah, no problem.
Very well. I think Dr. Hillman had to leave because he had some other appointment. And so with that, any other questions we can entertain? Otherwise, we have come to the end. And
I did submit a couple of them to Brandon directly.
Oh yes, I do see those here.
I see. Okay, go ahead.
Yeah. So the over-the-counter hearing. So what's your question about the over-the-counter hearing aid?
The question is, when we have over-the-counter hearing aids, we may just buy them, and in the meantime, we may be missing out some pathologies that are causing the problem.
Yeah,
That's a concern.
Yeah, so that definitely is a concern. Obviously, that goes to patient resistance in trying to come into the office. So if a patient kind of is aware that they have a problem, but they don't want to see the doctor yet, and they go for that over-the-counter hearing aid, it could potentially help them in the short term. But you're absolutely right. If it's something more concerning, like a sudden hearing loss in one ear, we miss out on that pathology if they don't come into the office.
Very well, Brandon. I think you did a super job. But thank you very much for your input and understanding on this topic. And I would now invite Dilip Desai, our Vice President, to wrap it up and give us some closing comments. Dilip?
Yes. how about an outstanding, stimulating, and so informative presentation? How about a big round of applause for our 3 experts?
Thank you.
Okay, so I tell you, I've been telling people that when we plan an event such as this, it is imperative for us to make sure that our experts they are willing to participate, and not only willing to participate, but their willingness to share your time and knowledge and all the education and experience with all of us. It was a super very informative presentation on hearing loss from all of you, sir. And to me, this was a complete package. Like this was totally integrated. We had an ENT surgeon, which is expert in ear, nose, and throat, like head and neck, which covers the ear. And then Dr. Hillman, he's a specialized in ears only, the otologist. And then we had a Brandon Levine, who is an audiologist. So this was a total package that we presented. We just observed and experienced today, and it was just outstanding. So we are really fortunate to have the 3 experts among us today, sharing all the knowledge. And what a nice presentation. Would it be possible, gentlemen, to have your presentation available for our audience?
Yeah, just let me know where you want me to send it to, and I can definitely email it out.
Yeah, question for Mr. Brandon Levine as well as Dr. Hillman. And we have a Vasu's presentation. And by the way, I have recorded the whole video as well. So once again, your detail on hearing system and the causes of hearing loss, including like hearing aid, the cochlear implant, the surgeries of PSAPs, implants. That was just, we all learned so much today. Not only learn, but I think something that it will be helpful to most of us. Like they say, 50% of the people are going to go through this process at stage of 70 plus, So once again, I can't say enough. What a great job you gentlemen did. And it was an awesome presentation. So thanks again. Thanks to all the viewers for supporting us, for coming regularly to our presentation. And I'm sure today's presentation exceeded your expectations. It did mine. I think it exceeded my expectations. And I end with that. Once again, thank you so much, gentlemen, for coming here and giving and sharing all your wisdom with us. Thank you.
By one more thing, along with that, guys, now in my last email, I given the path. You can go to our USAP website under the resource guide, the USAP event presentation, where you can find all the presentation copy. I already upload the last court presentation on the insurance, health insurance, as well as Ashwagandha. And as soon as we receive the presentation from the Braden and the Todd, we will definitely put it on our website so that you will get entire presentation copy available on the USAP website in next few days time.
Okay, with that, I want to thank you all, and we shall call it a day. Enjoy the rest of the day, and we will leave at this point. Thank you all very much.
Thank you.
Thank you for having me. Let's go Steelers.
Let's go.
You got it. Braden, are you living in the Upper St. Clair, right?
What?
You are living the Upper St. Clair.
Yes.
Okay.
I am also in Upper St. Clair, so I definitely see you sometimes.
Oh, I live in Mount Lebanon now, but yeah, I graduated from Upper St. Clair. I just moved to Mount Lebanon on Friday.
Oh, all the best to the new residents. And now officially we are adjourned. So thanks again, everybody. And my heartfelt thanks to the speakers.
Thank you.
Dr. Vasu and Dr. Todd Hillman and Mr. Brandon Levine. Awesome job.
Thank you, thank you. And Dr. Malapati, I will email you my presentation so we can get it to the right spot.
Great.
Thank
Alrighty.
you very much.
Have a good day, everybody.
Thank you.
Thank
Thank you, Dr. Malapati.
Okay, I am shutting it down.